Hello everyone. So this session is about cranial nerve 3, 4 and 6. So these are the SLOs about the session. And these are the content under which we have to describe the cranial nerves 3, 4 and 6. First, third cranial nerve, that is oculomotor nerve. Oculomotor nerve is purely motor nerve. It moves the eyeball and it supplies the muscles of the eyeball and has a role in accommodation. What are the functional components for the third cranial nerve or oculomotor nerve? So it has general somatic efferent, that means the muscle arising from the occipital somite. So they supply the muscles of the eyeball excluding lateral rectus and superior oblique, and the nucleus is present in the midbrain, okay, and the general visceral efferent, which is the nucleus known as Edinger-Westphal nucleus, and which is forming the parasympathetic component of the third nerve nucleus, which supply sphincter pupillae and ciliaris muscle. So course and relation. So third cranial nerve arise from the oculomotor sulcus on the medial aspect of the cerebral peduncle. Okay, here the medial aspect of the cerebral peduncle, and then it appears in the interpeduncular fossa. It is running forward and laterally between, first here you can see there is posterior cerebral artery and the superior cerebellar artery, and lateral to this one posterior communicating artery, it passes through the tentorial notch. Here you can see the tentorial notch of the tentorium cerebelli to reach the middle cranial fossa. It passes through here to the tentorial notch to reach the middle cranial fossa, and then it pierces the, here it can pierce the dura mater in oculomotor triangle, which is lying between the free and attached margin of tentorium cerebelli in the roof of the cavernous sinus. It enters the lateral wall of the cavernous sinus, and it lies superior to the fourth cranial nerve, ophthalmic and maxillary division of fifth cranial nerve, and also lateral to the internal carotid artery. In anterior part of cavernous sinus, it is dividing into upper and lower division, and these two divisions enter through the superior orbital fissure, and nasociliary nerve, which is branched from ophthalmic division of fifth cranial nerve, is present between the two divisions of oculomotor nerve. The smaller upper division, you can see here, it passes above the optic nerve and it supply superior rectus, here superior rectus and levator palpebrae superioris muscle, and the lower division is the bigger division which passes below the optic nerve, which supply medial rectus, which supply inferior rectus, and which also supply inferior oblique. The nerve to inferior oblique gives a motor root, the parasympathetic root, which is carrying the preganglionic parasympathetic fibers from the Edinger-Westphal nucleus, which relay at the ciliary ganglion. The postganglionic fibers pass through the short ciliary nerve and supply the sphincter pupillae and ciliaris muscle. So you can see here, this is the oculomotor nerve nucleus, and here is Edinger-Westphal nucleus, which is having the the spatial visceral efferent fibers, and here they are supplying here the sphincter pupillae and ciliaris muscle. Branches and distribution, we have already seen the general somatic efferent fibers will supply the superior division, giving the superior division which supply the superior rectus and levator palpebrae superioris. Inferior division supply medial rectus, inferior rectus and inferior oblique, And the general visceral efferent fiber, the parasympathetic fiber, preganglionic parasympathetic fibers, which relay at the ciliary ganglion, and postganglionic parasympathetic fibers from the ciliary ganglion will pass through the short ciliary nerve and will supply the sphincter pupillae and ciliaris muscle. Applied anatomy, the lesion of oculomotor nerve can be due to compression by aneurysm of posterior communicating artery, as it is passing between the posterior cerebral artery and superior cerebellar artery. Also, there can be compression by aneurysm of internal carotid artery, as it is passing through the lateral wall of cavernous sinus, and the compression can be by the transtentorial uncal herniation, as it passes through the tentorial notch. So these are the three sites where lesion to oculomotor nerve can happen. What can be the feature of the lesion of the oculomotor nerve, third cranial nerve? There can be ptosis because of paralysis of levator palpebrae superioris. There can be lateral squint or lateral strabismus due to paralysis of medial rectus, and there is unopposed action of lateral rectus. There can be dilated and fixed pupil because of paralysis of sphincter pupillae, and there is unopposed action of dilator pupillae. There can be loss of accommodation due to paralysis of medial rectus, sphincter pupillae and ciliaris muscle. There can be double vision or diplopia if looking medially, inferiorly and superiorly, again due to paralysis of medial rectus, inferior rectus and inferior oblique. And there can be proptosis, or you can see here prominence of eyeball due to relaxation of muscles of eyeball. Clinical testing of third cranial nerve can be tested by following ways, either by testing the eye muscle or by pupillary reflexes. Then fourth cranial nerve or trochlear nerve, it is the fourth cranial nerve. It is purely motor and it supplies only one muscle of the eyeball, that is superior oblique. It has few unique features. It is the only cranial nerve which emerge on the dorsal aspect of the brain. It is most slender cranial nerve. It is the smallest cranial nerve. Only cranial nerve whose nuclear fiber decussate before emerging on the surface of the brain. Okay, the nucleus receives only ipsilateral corticonuclear fiber, and phylogenetically it is the nerve of the third eye. Functional component and nuclei, it has only one functional component, that is general somatic efferent from the trochlear nucleus in the midbrain, okay, and it supplies superior oblique muscle. The course and relation, it arises from the dorsal aspect of midbrain on either side of frenulum villi. It winds around the superior cerebellar peduncle and cerebral peduncle just above the pons. You can see here the cerebral peduncle, and this is the trochlear nerve. It also passes between the posterior cerebral artery and superior cerebellar artery, and it lies medial to and below free margin of tentorium cerebellum. It enters the cavernous sinus. It runs forward in the lateral wall between the oculomotor and ophthalmic nerves. Okay, it crosses over the third cranial nerve, becomes lateral to it, and it enters the orbit through the superior orbital fissure. It runs medially above the levator palpebrae superioris to enter orbital surface of superior oblique, and it supply the superior oblique. That is the course and relation of the fourth cranial nerve or trochlear nerve. Branches and distribution, it supply only one muscle, that is superior oblique, and it has having the fibers from the general somatic efferent column. Applied anatomy, the paralysis of superior oblique can result in extortion of the eyeball and weakness of downward gaze. So there will be difficulty while going downstairs or reading newspaper, and also there will be diplopia if looking laterally and in glance on looking downward. So to compensate that, there will be head tilting to the opposite side. Now the sixth cranial nerve, abducent nerve, it is purely motor. It supplies lateral rectus. It abducts the eyeball, and it is also called as lover's nerve. The unique feature is it is most susceptible to damage during increased intracranial pressure. Functional component, it has two functional component, general somatic efferent, because it supply muscle arising from the occipital somoid, that is lateral rectus, and also it is having general somatic afferent, which terminate in the mesencephalic nucleus in the fifth cranial nerve. They carry the proprioceptive sensation from lateral rectus. So these are two functional column of abducent nerve. Course and relation, it arises at the lower border of the pons. Okay, so it is arising at the lower border of the pons, opposite pyramid of medulla. It pierces the dura mater over clivus inferolateral to the dorsal sella. Okay, you can see here, this is the sixth cranial nerve, inferolateral to the dorsum sella, and it is passing through the medial wall of inferior petrosal sinus. It enters the Doralus canal formed by apex of petrous temporal bone and petroclinoid ligament, which is also known as Gruber's ligament. So the cranial nerve which is related to Doralus canal is sixth cranial nerve. It enters the cavernous sinus by piercing the posterior wall close to the floor of the sinus. Here it is entering the cavernous sinus, and it is running forward inferolateral to internal carotid artery. It enters the orbit through superior orbital fissure here, and within the tendinous ring lateral to the two division of the oculomotor and nerve and the nasociliary nerve. So it is lying here in the superior orbital fissure. It is running forward toward lateral side to enter the orbital surface of the lateral rectus. So it is going to reach the lateral rectus and supply the lateral rectus. Branches and distribution, it is having the general somatic efferent fibers, so motor supply to lateral rectus, and it is having general somatic afferent fibers which carry the proprioceptive sensation from lateral rectus. Applied anatomy, it is the most commonly damaged nerve during increased intracranial pressure. Nerve is stretched due to descent of brainstem. Nerve is cut by sharp bony edge of petrous temporal bone. So because of that, there can be convergent squint due to unopposed action of the medial rectus. There can be inability to abduct the eye. There can be diplopia, double vision with maximum separation of two images while looking towards paralyzed sides. So that is the session on third, fourth and sixth cranial nerve. Thank you.